Hello guys, my name is Benson, and today with Muriel and Are, we are going to carry out the first demonstration on our mannequin. We promised you the last time that we're going to have a demonstration on how to place an epidural on a mannequin, and then we're going to have a second video again when we're going to place it directly on a live human being. So for today, we are going to use a mannequin. And as you know, at this point, I'm assuming that we already pre-visited this patient. We did all our pre-anesthetic assessment. We discussed all the contraindications with this patient, and we had her consent to go ahead with the epidural. So as of this point, you know that the epidural itself, the whole process from start to end is supposed to be sterile. However, when I'm placing my epidural, the first thing I do is that I wear normal gloves, which are just clean gloves. I position my patient. At that point, I position my patient and try to locate the space. Then after I locate the space, I can take out my clean gloves and then put on my sterile stuff, so that from that point henceforth, everything I'm going to be doing is going to be perfectly sterile. However, I'm going to get one of my colleagues, because the mannequin is kind of very straightforward, but I'm going to use one of my, Are's going to take a position in the chair there, so that we can show you the exact position by which the patient is supposed to assume for the success of this procedure, because the success of this procedure actually lies on good positioning. So I'm going to have that demonstrated on one of my colleagues here, but after that we're going to switch back to the mannequin. But you already have that mindset that this is the correct position that we're going to adapt when we're working directly on our live patient. So, we are assuming that this is our patient seated at this position, and as I explained to you, the success of the epidural depends pretty much on good positioning. A good positioning means that I want this patient to sit in such a way that her neck is supposed to come down and touch her chest. She's supposed to kind of arch her back and look like a kind of a cat, arch her back up. And when that is done, I want her to kind of raise her shoulders a little bit. By raising those shoulders and arching that back, it opens my spinal processes. It opens those processes so that I can feel them directly and know exactly where I'm going to. Now, if that is done, in the most part, there's always going to be somebody in front of this patient supporting the patient in such a way that the patient shouldn't fall out of the bed. So somebody, I assume that I can give the patient a pillow. She holds on that pillow, and then another person is supporting, because I'm going to be, when I start doing the epidural, I'm going to try to be, my hand is going to lie on her back, and I might be pushing so that the support from the front and the hand on my back stabilizes the patient, so that I can easily locate and go into that space without any issues. So assuming that that is done, what I do in the most part, I palpate. I palpate my vertebral column down. I palpate down. As I palpate down and reach where I think that can have my toughest line, where I have my iliac crest. My iliac crest between L3 and L4, that's exactly where I'm going to. So what I do is that I start a little bit up. Instead of L3, L4, I can start at L1, L2. I drop down to L2, L3, and then I go down to L3, L4. L3, L4, as we know, is the good position. That's a good space that we want to adapt for this procedure. So if I draw my line perpendicular from the two iliac crests across to the spinal, to the vertebral column, now I locate, and this is exactly my L3, L4 space where I'm going to be placing my epidural. Thank you. Hi guys, so here we have the patient already sitting down. So in the most part, what I'm going to do, I'm just going to try to locate my space before I start opening my sterile stuff. So I come back, I explain the procedure to the patient, and I just look at my space. Ma'am, I'm going to palpate your back here. Try to look at my space and draw a line down, filling my spaces. I go down, and as I move down my finger, I look at that, that's another space, that's one here. So I locate L3, L4, that's where I'm going to come back when I'm ready to infiltrate the skin. So now at this point, I'm going to drop my clean gloves. I'm going to put on my sterile gloves. on. I'm going to open my pack. The whole place is sterile. Drop this over there. Everything up in the sterile fashion. Got skin right here. My trichoderms. My betadine. Epidural catheter itself, which I'm just gonna open and leave it there ready for me, and come back to it. What I just said to do at this point, I'm gonna go ahead and just drop my skin to give the betadine time to dry on the skin, so as to be much effective. So, the purpose of this video, I'm not gonna use the betadine. I'm just going to use soda water here. I do 3 of them at a time, and then I come back. Let the patient know each time you want to do anything. Now I'm going to clean your back, doing a concentric circles. Just clean there, around. I drop it there. Second one. I drop. And the last one again. So at this point, I leave betadine there. It's going to continue drying. Then I come back to my sterile field and I start preparing my stuff. Remember, my 3cc needle go for my 1% lighter to infiltrate the skin. I'm going to draw using my filter needle. I'm going to draw my 1% lighter for the skin and take up to 3cc of it. Got it there. Do the rest here. Drop it here. And I go again. I use this one. I'm going to use to take my test dose for the skin, which is going to be my 1.5% lighter with AP. Drop my 1.5% lighter. That is supposed to be about 5 cc of it. Drop it down. And then I'm going to use my glass needle to take out my NS. I'm going to be using for to locate my epidural space. This I draw it up to here. Some people sometimes use air. Doesn't really matter as far as I know. Depends what you're comfortable with mostly. Everything is drawn up. I think that we are all set and ready to start rolling pretty soon here. Okay, at this point, the betadine is already settled there. What I'm going to do now, I'm going to apply my sterile drip on the back. Pull that out. So I do my sterile drip. It's open. Very sterile fashion. There. That space. Everything up. That's how it goes. When I come back, I'm explaining to the patient, ma'am, rub is already on your back. Very soon I'm going to start to locate that space. You will feel a little prick on your back. Immediately I get that done, you won't feel much pain again. I come back again. My hand rests on the iliac crest. Remember my space that I located before I started dropping? And that is the space I'm going to go in with my needle. So what I'm going to do, I'm going to create a small wheel there. Little wheel on the skin. And then I gradually go into the space while infiltrating. And at that point, I leave it there. What I usually do myself, I just leave the needle there. I drop it here. And then I can come back with my epidural needle. Epidural needle, Each of this mark is 1 centimeter. So in total, this epidural needle is 1, 2, 3, 4, 5, 6, 7, 8, 9, and the remaining part we can say is a 10 cc needle. So I come back to the skin, I take that blue needle off, drop it there, then I go back in the same space, my epidural needle looking upward, go through the different spaces. Once I enter inside the intraspinal ligament through the ligamentum flavum, I will stop because I start feeling that hard resistance. That's when I'm going to stop, and I draw out my trocar. Now this is the place where I bring out my glass syringe. I attach it to the herb of the needle, and I have to start now. Look at the way I attach it. My hands are holding the needle and the syringe together, and the other one resting on the back. I'm trying to locate the space. Gradually, I'm going in. Gradually, I'm going in. Gradually, I'm going in. So somebody's supposed to be in front supporting the patient for me. Here you go. That's a loss of resistance there. Loss of resistance. The whole needle was 10. So this is 10. This is 9. This is 8. So most likely I'm at about 7.5 at this position. So if I leave 3 centimeters into the skin, when I come out with my catheter, I should be at a level of about 10.5 on the skin. I drop it there. I come back here and I take my catheter. I get it in a little bit, stabilize the catheter with this, and then I drop it inside. Here we go, here we go, here we go. And finally, I am at the position where I want it to be. Send it on more. Some people might like to send a little bit more than 3, so that by the time you come out, you're stabilizing your catheter. Remember, when I come out, I want to be at a 10 centimeters mark when I come out on the skin. So this is 15, the three marks, 15, that is 12, and that is 10 there. I get here and I'm exactly at 10 where I want it to be. So at this point, I'm going to go ahead and attach my catheter holder right up there. Press it firm, very firm. And this is the point where we're going to do our test dose. Ma'am, we got this. We located a space, and at this point, I'm going to go ahead and give a test dose. If you hear any ringing ears, or you feel like your heart is beginning to beat a lot, or you have some type of bitter taste in your mouth, please you let me know. As I'm injecting, I'm going to give 3 cc's of my 1.5% Lido, and we are going to wait for the full 1 minute to see if it is negative. Negative means that we're not going to have any increase in heart rate or any blood pressure if the patient is not complaining of any of those things that I spoke about. So I'm going to inject 3 cc of that. Is it going in? Well, 3 cc is in, and we're going to wait for total 1 minute. We aspirated, it was negative. Send in 3 cc's, and we waited for 1 minute to see if we are going to see any increase in heart rate or any changes in our blood pressure. 1 minute is over. No complaints from mom, no increase in heart rate, no hypertension, nothing. So we can go ahead and finish. Before we finish it again, we aspirate to be sure that everything is still negative. We finish the remaining 2 cc's. The remaining 2 cc's are in. Take it off. Go ahead and prime my filter a little bit here. Just before I finish the remaining, just prime my filter. It is prime. And I'm gonna attach it. Attach it there now at this point, and then everything is fixed. Go ahead, close it up. I think our epidural is all set. And from this point now, we are going to put our tegaderm on it. So the tegaderm we're going to use to stabilize our catheter on the back. And then we can put a plaster right over catheter on top of the whole catheter and stabilize it so that it's ready for use. There are 2 ways now from this point. We can either do a continuous infusion in the setup where they have infusion pumps, or in our context here in Cameroon, we are going to be doing boluses. In a subsequent video, we are going to show the different dilutions and how we are going to, what concentration and what amount we are going to use to bolus these patients during the process of their labor. And I think this is basically what it takes to place an epidural catheter. Thank you very much.